Morning. I'm so sorry about the delay. We had a few technical difficulties. Just to reintroduce, my name is Tana Coe, and dietitians working here at Hertiscare within the ENT department. And I'm going to be speaking today on refeeding syndrome in head and neck cancer patients. So malnutrition is a big problem within the head and neck cancer patient population. We know that 35 to 60% of patients are malnourished at the time of diagnosis, and 80% of patients have a significant unintentional weight loss during their treatment. We also know that malnutrition is significantly more frequent in men, in elderly subjects, in patients who suffer from alcohol abuse, in pharyngeal tumors, as well as advanced tumor age. And this is a problem because malnutrition worsens outcomes. So there's a whole host of negative effects that come with malnutrition. And when we're dealing with these very unwell surgical patients, these effects can be quite detrimental. So, for example, delayed wound healing or increased risk of infection. These are big problems that we see in the patients within the ENT group. So if we consider the cause of malnutrition within this patient group, there we go. All right. So these are the effects of malnutrition on outcome that were discussed previously. So if we consider the reason for malnutrition within this patient group, firstly, we see a decrease in nutritional intake, largely due to the location of the disease. So there's obstructing symptoms, dysphagia, agenophagia. You also get the anorexia that can come with cancer. And then on the other side of the scale, we see an increase in metabolic demand, usually due to the cancer hypermetabolism, surgery, or infection. So what we see in some patients is that their oral intake seems to remain the same. However, they still get this increased demand that we see within head and neck cancer. So what this causes is a relative starvation. So these patients aren't necessarily eating less, but because there's an increase in their metabolic demand, they are in a deficit, and it's this deficit that would then cause malnutrition. But this type of malnutrition would be much slower than a patient who has decreased intake as well as an increase in metabolic demand. This is unfortunately the majority of our patients, and we see a very large deficit in nutritional intake and a huge progression of malnutrition. So now if we consider what refeeding syndrome is, it's a life-threatening complication involving the reintroduction or the increased provision of calories. And it's characterized by electrolyte disturbances and fluid imbalances, which we'll discuss shortly. Just a brief view at the history of refeeding syndrome. So it was first reported after World War II, where starving prisoners were refed, and they experienced cardiac and neurological symptoms after refeeding. And quite a few people actually died from this after the war. Then we see the Minnesota starvation experiment, quite an interesting experiment done by a physician and a psychologist, something that definitely would not get ethical approval today. But in this experiment, they fed a group of men who were conscious objectors to World War II 3,200 calories. They went through a deficit phase, which they called the starvation phase, where these patients were only fed 1,500 calories. So 1,500 calories is still a lot of calories, but relative to what these people needed, it was quite a huge deficit from their normal intake. And then they again raised the calories up to their baseline levels. And what they saw in this experiment was that upon replenishment of nutrition, some of the subjects developed heart failure, which may be attributed to hypophosphatemia. So they're definitely starting to see the link between hypophosphatemia and heart failure, but they hadn't quite yet named refeeding syndrome as such. And then since the 1950s, the definitions have started to come out about refeeding syndrome, but there's unfortunately a huge amount of variety between the definitions, and a lot of them are very vague. So some studies even report definitions which may occur when normal intake is resumed after a period of starvation, which is very vague and really makes it quite difficult to do research within this topic. So if we then consider the incidence is largely unknown. The reported incidence may be around 30%, but it's likely much more prevalent than this. A lot of studies report the incidences being between 0 and 80%. So as you can see, the lack of definition really creates a huge issue when it comes to calculating, what is the actual incidence of refeeding syndrome. Between the definitions, there is some consensus. So most definitions will include the fact that hypophosphatemia is usually present, and the time of onset is usually standard throughout the different definitions, being within the first 72 to 96 hours after starting nutritional therapy. What you also see, though, is that because the research is so poor within refeeding syndrome, often patient groups are grouped together, and there's a very heterogeneous patient population and very, very few studies on head and neck cancer in particular, which we will see shortly during the rest of the presentation. What I do want to just say is that because refeeding syndrome is a condition that comes from malnutrition, I think that it doesn't really discriminate between patient groups. But I will say that because the head and neck cancer patients do have such a high risk of malnutrition, especially the patients that we see here at Groote Hospital, I think it's important to note that the refeeding syndrome risk may be higher in this population than it is for the general heterogeneous surgical population. But obviously, this is it's just actually based on facts, and that's why it really would be great to do some research within this area. So a lot of studies will also speak about the degree of refeeding syndrome, saying that it exists on a spectrum, and there's often two entities that people will discuss within the literature. Firstly, a florid refeeding syndrome, which has clinical manifestations because of the electrolyte disturbances. So, for example, heart failure due to low phosphate levels. But they also speak about a subclinical refeeding syndrome, which is basically a decrease in biochemical values. So there'll be some electrolyte derangements, which can then be dealt with to prevent florid refeeding syndrome from presenting. And often this subclinical refeeding syndrome is spoken about as a refeeding hypophosphatemia or a refeeding phenomena, and not necessarily refeeding syndrome per se. So if we consider the process of refeeding syndrome, so during normal intake, your body will cycle through your postprandial and fasting states, and your body metabolism will adjust according to what state you're in. So if we start right at the top with glycogen stores utilized, this is during a state of starvation or relative starvation. In this state, you have a decreased insulin and an increased glucagon secretion. This is to mobilize your glycogen stores for energy. We also see gluconeogenesis, where protein and lipids are metabolized in order to release energy. And from this, we see a protein, fat, mineral, electrolyte, and vitamin depletion within the body, which also results in sodium and water intolerances. Then at the bottom, upon refeeding, where carbohydrate is the main source of energy, your body switches from a catabolic to an anabolic phase. You have an increase in insulin secretion, which results in an increased glucose uptake, an increased uptake of your electrolytes, which results in a net decrease within your serum, as well as an increased utilization of thiamine. So if we look on a more cellular level, there are two key events that happen. Firstly, when the insulin levels increase upon refeeding, this drives glucose phosphate as well as thiamine within our cells in order to undergo the breakdown of glucose in order to release energy. So if we consider the final step of this process, which would be the phosphorylation of ADP to ATP, this process uses up phosphate, and that's why we often see phosphate being the electrolyte that's most greatly depleted within refeeding syndrome. But thiamine is also necessary within this process, and therefore thiamine gets further depleted. During this process, we also have our sodium-potassium pumps along the cells, which will pump potassium and magnesium into the cell and push sodium out. We also know that with an increase in insulin, we tend to see a sodium reabsorption in our kidneys, and that further exacerbates the increase in sodium as well as the increase in edema within these patients, which may then result in some of the clinical symptoms we see with refeeding syndrome. So overall, if we consider the metabolic and electrolyte derangements within refeeding syndrome, there's a whole host of electrolyte derangements in this list, but the most common or the most prevalent is definitely the hypophosphatemia that we see within refeeding syndrome. And it's important to note that not only is refeeding hypophosphatemia present if phosphate levels are low, so less than 0.65, but also if there's been a decrease in phosphate of more than 0.15. So if the phosphate levels went from 1.4 down to 1 would still be a normal phosphate level, but we do need to consider that this drop may be related to a refeeding hypophosphatemia. So how do we identify risk? So there's two main methods proposed by the literature. There's the Aspen consensus for identifying patients at risk. Aspen is the American Society for Parenteral and Enteral Nutrition. There's also the European Society for Enteral and Parenteral Nutrition, and that's where we actually get most of our nutritional guidelines and recommendations from. So they've got a consensus paper where they speak about identifying risk based on moderate risk or significant risk. Moderate risk means at least 2 of the following criteria are met, and they give different criteria based on BMI, weight loss, caloric intake, abnormal electrolyte levels, as well as loss of fat or muscle tissue. And then significant risk if more than 1 of the following risk factors are met. And these follow the same criteria, but they would be a more severe form. So for example, moderate risk would be BMI between 16 and 18.5, whereas significant risk is less than 16. There's also the NICE guidelines. These guidelines are very similar to the Aspen consensus guidelines, and they help us again to identify risk. So you'll notice the pattern that most of the recommendations focus on not only BMI, because you can get a patient with a normal BMI who's lost a significant amount of weight, but it also focuses on weight loss, a reduction in oral intake, as well as low electrolyte levels. And some of the guidelines also include other risk factors, for example, a history of alcohol abuse, which unfortunately we do see a lot in this patient population. Aspen also proposes a graded diagnosis of refeeding syndrome. So this basically allows us to diagnose refeeding syndrome as mild, moderate, or severe based on the percentage decrease in our electrolyte levels. So this is quite a useful classification to use within research to actually classify the degree of refeeding syndrome experienced by patients. So if we have a look at the literature available, so based on my research, there are 2 main reviews that focus on refeeding syndrome and head and neck cancer. The one is from a nursing journal out of China, and it doesn't really offer new insights or it doesn't offer as much good information as this review did. So I chose to focus rather on this review. And basically, the goals of this review were to raise awareness about refeeding syndrome, as well as create a comprehensive presentation of all of the recent guidelines. So a lot of the guidelines are actually from recommendations and books and articles and reviews, and there isn't much statistical analysis within this review. So the methods was that they did a review of the literature, which focused on nutritional assessment and refeeding syndrome management between 2005 and 2017. And they compiled this review, which we'll go through. So they identify 3 factors that appear to be fundamental when dealing with refeeding syndrome. So firstly, the early diagnosis of at-risk patients. And for this, they recommend the first step being nutritional status assessment and screening for malnutrition. The second, developing an appropriate feeding protocol. So the second step they recommend is screening for patients at high risk for refeeding syndrome in order to determine what feeding protocol you should follow. And then lastly, the monitoring during refeeding syndrome. So step 3 would be refeeding initiation and monitoring during refeeding. So if we consider the first step, nutritional status assessment and screening for malnutrition, the purpose of nutritional screening is to identify patients who require early nutritional intervention, and this should prompt the referral onto a multidisciplinary team. Most guidelines will recommend screening as early as possible, so not only just before surgery, but rather upon diagnosis. But there's really a lack of consensus on which is the best method and which tool we should be using. But most of the recommendations say that your screening process should include anthropometric measurements such as weight, height, and BMI, changes in oral intake, loss of weight, as well as any of the warning signs that we see commonly within this head and neck cancer patient population. So this is a screening tool that is often spoken about. It's the NRS 2002 screening tool. It is a validated screening tool, and it's the best predictor of post-surgical complications as well as length of stay. It's also validated within the cancer population and has been shown to be associated with refeeding syndrome. So it fits this patient population group really well. And what I really like about the screening tool is that this first part of the screening tool, where they look at, does the patient have a low weight? Has the patient lost weight? Has the patient had reduced intake? And is the patient severely ill? These are questions that even the patient could answer. So it doesn't necessarily require a healthcare professional to answer. And it's quite a useful tool also at a nursing level to be able to answer. And it's quite a nice way to stratify patients on whether or not they would need a dietetic referral, for example. It then splits up into the next step, which basically grades the patient's full risk of malnutrition from mild to severe, based on impaired nutritional status and the severity of illness. So if patients score 3 or above, they're at risk of malnutrition. And if patients score more than 5, this is associated with considerably poorer outcomes. So just to mention that a head and neck cancer surgery would fall within score 1, and then post-surgery would fall under 0.2. Within this review, they also speak about the indications for artificial nutrition, which are very similar to the risk of malnutrition scoring factors. So I thought it was quite interesting just to have a look at those. And luckily, we've definitely seen an increase in artificial nutrition within the head and neck cancer patients that we see at Curtis here. And I don't think it's necessarily because the patients have gotten worse. I think it's actually because we've become a lot better at referring patients early and really pushing for nutritional support early within the process. It's been great to see a lot of our patients actually getting nasogastric feeds prior to surgery for a few weeks to build them up for their big surgeries. So the second step would be screening for high-risk patients. So again, the nice criteria, just a different picture, which focuses on those 4 areas that come up a lot within the identifying risk within patients. So this is the guidelines that this review recommends. And then they give a table which outlines the risk factors associated with refeeding syndrome. And in our patient group, we see many of these risk factors prevalent. Obviously, this is a paper that is pointing towards head and neck cancer patients. So it is obvious that a lot of these would relate to head and neck cancer patients. But I think it's just important to note that refeeding syndrome is an incredibly prevalent risk within this patient group. They also speak about a prospective observational study, which I'm going to go into in a little bit more detail, where they looked at a population of head and neck cancer patients, and they found that 20% of the patients were developed refeeding syndrome, 72% developed either refeeding syndrome or just a decline in their phosphate levels. And they also looked at the risk factors most strongly associated with refeeding syndrome. I'm not going to go into this too much because we will touch on it a little bit later. Then the third step they recommend would be the refeeding initiation and monitoring. So when malnutrition is detected, they recommend early nutritional intervention, but we do need to focus on the fact that there can be a derangement in electrolytes, which can result in severe clinical manifestations if we are not closely monitoring electrolytes during nutritional support. So this is a really nice flow diagram that they outline in terms of the management of refeeding syndrome in patients. So if we start right at the top in the red, the first step would be screening for patients at high risk of malnutrition or patients needing nutritional intervention. The next step would be screening for high risk for refeeding syndrome. So they recommend using the NICE guidelines. Then it splits into the patients at high risk for developing refeeding syndrome and the moderate risk for developing refeeding syndrome. So if we focus on the left first at the high risk for developing refeeding syndrome, they recommend that these patients get hospitalized as well as a dietetic assessment. It then further splits off into the patients who have a dietary intake of more than 2/3 of their recommended daily intake, or patients who are getting less than 2/3 of their daily recommended intake. So if we focus first on the left, on the more than 2/3 of their daily recommended intake, these patients are managing to eat most of their requirements. So therefore, they recommend oral feeding. They recommend starting from previous energy levels and increasing over a few days. They recommend using enriched foods as well as our oral nutritional supplement shakes that we provide. And they recommend daily oral intake evaluation and adjustments. However, failing this, they recommend moving over to the side that involves enteral feeding. So this would be for the patients who are unable to reach 2/3 of their daily recommended intake. And here they recommend a slow progression of nutritional intake between 5 and 10 calories per kilogram, and slowly progressing over the next week in order to reach the goal requirements. So most of our patients tend to follow this process, especially when they come up from surgery with their enteral feeding tubes. If we look at the bottom where they speak about the electrolyte supplementation. So in this patient group who are high risk for refeeding syndrome, they actually recommend systemic supplementation for 1 week of phosphate, magnesium, and thiamine. So at the moment, we are supplementing thiamine in all of these patients, but phosphorus and magnesium, we are not supplementing all of our patients in a high-risk for refeeding syndrome group. We are actually monitoring values and then supplementing as needed. So it's quite interesting to see that they actually recommend blanket supplementation for all patients at high risk for refeeding syndrome. In terms of potassium and calcium, they recommend checking and replacing as needed. In terms of monitoring, they recommend daily electrolyte monitoring for clinical symptoms as appropriate, and then if electrolyte deficiencies appear, to keep feeding at the same rate and supplement electrolytes. Then if we move over on the right-hand side of this graph to the moderate risk of refeeding syndrome, again, it's split into the more than 2/3 of intake and less than 2/3 of intake. It follows a similar process where failing oral intake, they recommend enteral feeding. But in this patient group, they recommend a much faster progression to full caloric requirements. They recommend no need for systemic initial supplementation, and just that electrolytes are monitored 24 to 48 hours after feed initiation, and then just to replace electrolytes as they become deficient. So it's quite a comprehensive guideline to follow. And I think, you know, the blanket provision of electrolytes within that first week, it may actually really help us to progress oral intake much faster. In terms of electrolyte replacement, so if we consider phosphate, they recommend covering the daily requirements of phosphate for the first week. And that would be about 750 milligrams or 0.3 to 0.6 millimoles per kilogram per day. Just to mention that in the phosphate enema that we very often use within this patient group, where we give the 2.3 ml flushes down the nasogastric tube, this has 16 millimoles of phosphate. So it covers the requirements quite nicely. And for absorption, they actually recommend giving 2 doses of oral or nasogastric tube phosphate per day. In cases of severe phosphate depletion, they recommend IV supplementation. In terms of magnesium, they also recommend systemic magnesium supplementation, which can be done orally or in these patients via a nasogastric tube. And then for potassium and calcium, they recommend only supplementing if deficiency is found. So thiamine becomes a very important component of our refeeding syndrome protocols. It's an essential coenzyme in carbohydrate metabolism, and deficiency is a consequence often of chronic alcohol consumption as well as inadequate intake. And it can result in very severe manifestations such as Wernicke's encephalopathy. The acute symptoms are usually precipitated by glucose intake, so it's actually important to supplement with thiamine prior to feeding initiation. And thiamine isn't stored, so it's very quickly depleted within the body. They very often recommend very high initial doses of thiamine in order to cross the blood-brain barrier and restore the vitamin status of these patients, especially in the alcoholic patients. And the recommended dose is around 200 to 300 milligrams of thiamine per day, and this is recommended for at least a week. Just something on thiamine that I would like to mention, often patients as outpatients, for example, from the clinic or any other outpatient clinic, will be referred to dietetics for nutritional supplementation. And it really helps if thiamine is actually boarded on the prescription charts that these outpatients get, because obviously we do want to start pushing the oral intake as outpatients, but we always have to be a little bit careful of refeeding syndrome. So to have thiamine boarded is incredibly helpful. And the cost of thiamine is incredibly affordable. So that comes in at around, if you do the usual dose of around 200 milligrams BD that we do here usually for most of our patients, that's around less than R1 a day. So the affordability of it is it's a very good characteristic about the thiamine supplementation that we use. So in terms of monitoring, so again, slow progressive feeding is important in order to reduce the risk of refeeding syndrome, and close monitoring becomes incredibly important. So they recommend that the plasma electrolyte levels, particularly phosphate, magnesium, sodium, and potassium, should be monitored daily for at least the first 4 days. So obviously, in a very financially constrained environment, this does become challenging. They recommend that if electrolyte deficits appear, or if there's any clinical manifestations that feeding should be stopped. Feeding shouldn't be stopped. Caloric intake should just be halted, and the electrolyte should be replaced as needed. However, if there's severe hypophosphatemia, so less than 0.3, I've once seen a 0.1 phosphate, which is obviously very, very low, then you should stop feeding and replace levels and only resume feeding once the levels have normalized. So this is the study that they mentioned in the review. It's a study that was done in Denmark, and it's one of the only of its kind that I could find, where they actually looked at the incidence and the risk factors for developing refeeding syndrome within a head and neck cancer population. So it's an observational study where their goals were to determine the incident rates of firstly refeeding phenomena, which would be declined as just a decline in phosphate levels upon feeding, as well as refeeding syndrome. So this would be the development of the clinical symptoms of refeeding syndrome in addition to a decline in phosphate. I think it's important to note that these symptoms of refeeding syndrome are very general. So things like arrhythmias, hypertension, confusion, these are symptoms that we see a lot within any hospital setting. So it's quite, we are kind of diagnosing these patients as refeeding syndrome patients, but I think it is important to note that there could be other reasons for these clinical manifestations, which I think is another factor which makes refeeding syndrome research quite challenging. And lastly, the goal of this research was to identify the risk factors. So they actually looked at the patients that developed refeeding syndrome and crossed this with the risk factors that these patients possess. So this is a review of the baseline characteristics of the study population. So it was a very small study of only 54 patients. What I would like to point out is that this sample, in my opinion, is not representative of the South African population. The average BMI was overweight. The nutritional status at baseline, you can see 57% had an above normal nutritional status. And if we consider weight loss at baseline, only 50% had experienced weight loss at baseline. And, it's difficult to say because we haven't actually done research within this area, but my feeling is that the population that we see here are much worse off than this sample group. So I think it's just important to consider that when we look at the results. And also, I think it just indicates the importance of actually doing nutritional status studies within this patient population here at Refeeding. So in terms of the method, so samples were collected for these patients at baseline on day 2, day 4, and day 7 in order to check baseline and subsequent electrolyte levels. And another flaw of this research is that the nutrition advice was taken care of by the nursing staff. And nursing staff do the most amazing job in what they do. But my feeling is that nursing staff should not be the members of the team who are providing nutritional advice, especially to such a high-risk patient group. And in terms of nutritional support, they say sometimes oral nutritional supplements were given and very seldom tube feeds were started. So also not really representative of the types of patients that we see here. And I would also like to mention that tube feeding in itself is a risk factor for developing refeeding syndrome. So that also can push up the incidence of refeeding syndrome. So they looked at the potential factors defining the high-risk groups, which they selected from published literature. And then they compared this to the patients that developed refeeding syndrome or refeeding phenomena. Some baseline information that they collected was diet history, hand grip strength, physical performance measurements, and they measured nutritional status using the NRS 2002. They calculated refeeding risk based on the NICE guidelines, and then they also looked at head and neck pain. So just to highlight some of the results. So in total, 39 subjects, which is 72%, developed either refeeding syndrome or refeeding hypophosphatemia. 11 patients of the group, which is 20%, developed refeeding syndrome. So there were actually 12 that developed the clinical symptoms of refeeding syndrome, but one of them did not have a decline in their phosphate level and therefore was excluded as a refeeding syndrome case. The most common clinical symptom was hypertension, which is actually very, very common in your post-surgical response, especially if there is sepsis involved. And the second was edema, followed by dyspnea and confusion. 28 subjects developed refeeding phenomena, which is 52%. What they found based on the pre-surgical data is that only 46% of patients met their energy requirements, which was actually 41% if they excluded alcohol from the energy requirement calculation, which I think is quite harrowing to see that for some people, 5% of their daily intake is alcohol. And then if they looked at day 2, day 4, and day 7, only 4%, 19%, and 21% of patients met their energy requirements. This graph just shows the association between the percentage of energy cover and the decline in phosphate levels. So obviously, the more you feed a patient's requirements early on, the lower their phosphate may drop, and that's what this graph outlines. So if we look at the risk factors that we identified from the study, they found that presence of eating difficulties, alcohol intake, poor hand grip strength, a history of radiation, higher phosphate levels, and then low sodium and transferrin levels were associated with refeeding syndrome within this patient group. And I think what's great about doing research of this kind is that it helps you to create risk stratification in terms of your protocols for managing refeeding syndrome. I would just like to mention this study by Kritkite. So it's actually a study done in chronic disease. So it focuses quite a lot on diabetes. But what I really like about this study is that they very clearly stratify the methods for managing refeeding syndrome based on risk. And I think something like this could be really useful in a setting such as the setting that we have here at Hertiscare, because some patients, we could probably progress their oral intake much faster than others based on their nutritional risk. But unfortunately, we kind of will, because I would be managing the nutrition, will group patients all as having a risk for refeeding syndrome and all as having a nutritional risk. And often within the first week, you don't meet the patient's requirements and they actually tend to lose some weight after surgery, which obviously we would like to avoid. So I like the idea of really classifying, managing patients based on risk. So on this next page, they actually speak step by step about the different processes that you would take in managing patients of different risks. So for example, the blanket supplementation, which would be for all the groups, would be your thiamine supplementation, which should be started 30 minutes before feeding, and then thiamine supplementation we usually give it for around the first week or longer. And then the progression of nutrition support. So you can see if you look at the low risk for refeeding syndrome, which is the yellow column, you would start at around 15 to 25 calories per kilogram. However, in the very high risk for refeeding syndrome group on the right, in the red, you would start at only about 5 to 10 calories per kilogram, which is actually where most of our patients' nutritional prescriptions start. And then again, they outline monitoring. So in terms of electrolyte levels, they recommend from day 1 to 3 monitoring daily, day 4 to 6 monitoring every second day, and then day 7 to 10 monitoring once a week. So just to end off, this is based on a discussion that I had with Nat, where he discussed some of the potential research topics that we could do within nutrition and refeeding syndrome. So firstly, I think it would be really great to do some sort of prospective cohort study where we do quite a similar study to what they did in that Rasmussen trial from Denmark, where we actually look at the rates of refeeding syndrome within a patient population, as well as the risk factors that increase the chance of refeeding syndrome within those patients. So this will help us to develop a more risk stratified based management approach to these patients. And really, I think what's quite important is to develop a protocol for the management of refeeding syndrome within a resource-constrained environment, maybe within an environment where people may not be able to afford to do bloods on a daily basis, or maybe even just provision of nutritional supplementation on an outpatient level, or provision of enteral nutrition on an outpatient level becomes quite difficult. So I think it would really be great to try and come up with a protocol for management when resources are lacking, and at which stage would it be best to test electrolyte levels that you can still monitor these patients effectively, but without wasting resources. And then just at the bottom, just in terms of other research topics. So there was a research topic started a few years ago, but unfortunately it never ever got to being done. But the protocol has been developed by previous members of the team. where they look at the nutritional status of the patients presenting with head and neck cancer to her to scare. To me, this is an incredibly important study, and I'd really like to get this up and running again. I'm hoping to join the research meeting that's happening in July. Is it June or July? I can't remember, but I am hopefully planning to join that meeting because, to me, that's a really important baseline study in order to get data out on what is the nutritional status of head and neck cancer patients within an African population. And I think from there, we really could do so much more research to come. For example, looking at nutritional status and outcome, and maybe trying to, see what is the correlation between nutritional risk and outcome within the patients that we see here. So that is all from me today. I hope that provides a little bit more insight into the research in refeeding syndrome and head and neck cancer, or rather maybe the lack of research within refeeding syndrome and head and neck cancer. But yeah, I just want to reiterate that within the South African population, our population differs so much from the populations in the first world. And I think that if we're considering, at large, the South African population that we see are at risk of even without head and neck cancer, unfortunately. So we can't make conclusions that aren't there. So I think this research is very important, and hopefully we can get it going this year.
Great, yeah. Thank you very much. It's very good. Another thing mentioned that about 60% of the patients are malnourished. So there's a first course studies on that.
Yeah.
I mean, how it might be with the patients of chronically malnourished anyway, with poverty.
Absolutely.
So I think that'd be really, I believe in. Now, so when the patient starve this overnight, it's not feed the next day.
Yeah.
I'm sure the others at risk of refeeding syndrome because they need a risk every day when you have that.
Yeah, absolutely.
So I can't understand it because I don't understand in a organ industry is fasting. You fast for how many hours? 12-15 hours, right? I mean, when she eats in the evening, is she at risk of refeeding syndrome every time she eats?
No. So basically, and just to give you an example of this, so for example, one of our patients that we built up prior to surgery, we're giving huge amounts of energy requirements prior to surgery, and then we have the surgery, and then afterwards, you're in this gray area where do you go straight back up to our requirements? I think the risk of refeeding syndrome in that case isn't there. So over a 12-hour, 24-hour fast, I don't think the risk of refeeding syndrome comes. But what we do have to consider is that within surgical stress, you have a certain level of endogenous glucose production. So post-surgery, and we see this especially in ICU patients. Something to consider is that in private, these patients we see day 1 first and day 2, they don't even ICU. So, obviously we treat them as ward patients with extra care, but overseas they may be classified as ICU patients. But when we see patients in ICU post-event surgery, we have to consider that there will be an aspect of endogenous glucose production, and overfeeding in those very, very early phases post-surgery, especially a very extensive surgery, can be very harmful, and there's documented negative effects of overfeeding soon after surgery. But basically, to answer your question, the risk of refeeding syndrome per se won't be there, but the risk of overfeeding too early post-surgery may still be there. So, in those patients, you would progress our intake much quicker, and those patients I usually start with the concentrated feed they were on before, instead of going all the way back to breastfed original, which is a very unconcentrated feed, and maybe just starting at a lower rate and aiming to increase the rate over the next 2 days to get back to goal. But would I go straight back to goal as they hang up the feet post-surgery? Probably not, because of the endogenous glucose production and the surgical stress that occurs.
Do you think it also applies to head and neck surgery because you have been made it last maybe estimating what we do this.
Yeah, no, it's a very good point. So a lot of the research with the huge amounts of endogenous glucose production is usually done in trauma patients, and that's where most of the research actually comes from. So yeah, I definitely hear what you're saying, that it may not be as extensive within this patient within this patient group.
Yeah, so that might also be worthwhile looking at.
Yeah.
And then the other group of patients that really worry in the hospital are the ones that get cancelled, and they start for days on end.
Yeah.
And that happens all the time. And they must be very high risk.
Absolutely. Absolutely.
Yeah.
Yeah.
And using a track effect, and they sometimes are literally stop for 2 days. I think.
Yeah, it's a big problem.
That might be good to look at as well.
Yeah.
And then it's phosphate a good marker for refeeding, you know, in the sense that you don't have to do all the other markers.
So I would say in a resource limited environment, yes, I would say it's definitely the most sensitive when looking at refeeding syndrome. And if we had to pick one, I would pick phosphate. What I will say as well is that when we are feeding patients artificially, we should be monitoring their electrolytes and hydration status once a week. So once they pass that initial refeeding phase, because we do see, because it's not a natural way of eating or drinking, and they might be incredibly thirsty the entire time, but they're not allowed to drink already, it's all going through the tube. So we do see severe dehydration in these patients. We've seen it before, with incredibly high sodium, incredibly high ureas. So definitely in the initial phases, if we really limited, and we have to limit it to one value, I would say phosphate. But I would recommend at least looking at hydration and electrolytes once a week if they're artificially.
Did you target it? What did you target?
Yeah, I mean, it's much the same, obviously, in terms of patient presentation. And yeah, just trying to start supplementation as early as possible. Once they're diagnosed, try and work them up. But they don't routinely give artificial through any tube. They do give the shakes as they plan for surgery to try and
Right, sure.
just for the first few weeks. It's a few weeks if they're waiting.
So most of our patients are managed that way. They'll usually come through to our outpatient department, get nutritional supplements. But in the patients that really struggle, and the patients that come in and their nutrition is very, very flat, we've been quite proactive at bringing in gastric tube, sending them further and bringing them back for surgery.
Great idea. This is not even console.
Yeah.
Yeah, I mean, we obviously see it quite frequently. I just wonder how many of those patients, because if you compare our population, state the Fox population and private, they're completely different.
Yeah.
You agree? They just, I wonder how many of our patients just, even before their cancer, they had poor diet from childhood.
Yeah.
And so I just wonder if the risk is in fact the same, because this is a chronic malnutrition versus just an acute due to a cancer.
Yeah.
That comes into play. And then the other thing for those patients that are where you suspect the weight loss is out of keeping with the tumor per se and the intake, we do also screen for underlying TB, because that's quite right now. I think it's important to consider. And then it's useful to have I think the screening tool, which you guys use obviously all the time, is useful, but for the clinician, I think something which you mentioned, which is very short and sweet and very easy to use, rather than a whole bunch of risk factors which nobody ever really is going to have the time to look at. Yeah, I think that's just really quick and easy. And which is management based, which will so mild, moderate, and high, and just easy screening tools for that.
Yeah.
That one can easily remember. Yeah.
Do you think, like, as part of the LE clinic?
Yeah, as part of the LE clinic, just to have a protocol, but having a screening tool, which is really, really useful. And BMI is not always useful. Yeah. BMI and weight is not always useful in our population. I mean, we often see that they're skeletal, but they've been like that their whole life. Yeah. And that's not really useful indication for this.
Definitely. Or you see a patient with a BMI of 26, but the BMI used to be 40 months ago. And even that would be a severe risk. Absolutely. The study that was started a few years ago on the nutritional risk of patients, back then we didn't have some of the really amazing equipment that we have. So we've got in-body machines which actually measure muscle, water, bone, fat. They give a measure of the phase angle, which basically shows cell integrity and has been correlated with mortality risk and surgical outcomes. So we've got really amazing equipment that's free to use because our department owns them and give really good insight. So it would be quite nice to not only assess the nutritional status as in weight loss BMI, but also maybe look at muscle mass and fat mass and all of those factors as well. So it would be great to incorporate that into the protocol as well.
That would make you famous.
That would be great stuff.
So can I ask a question? So, we recently had a patient in the ward who's very basic. Well, we have lots of those, but there was one that we were wanting to sort of optimize in terms of nutrition prior to the surgery. And you asked a very important question like, what is the endpoint? And what is the endpoint there? I'm not sure what happened to that particular patient from. Do you remember?
Yeah, I do.
So we were like, and even in my head, I was like, okay, so when would he be fit for surgery in terms of his nutrition? Because his weight's not going to go up, or maybe it would, I don't know. And so what is the endpoint if you're wanting to optimize nutrition? What do you look at?
So it's a very good question. The literature doesn't give an exact answer. Basically, I think, and what we discussed as a department is that if a patient's nutritional status is improving, they're in an anabolic phase, and that would in itself improve outcomes. Just to give you an idea as well, ESPEN, which is the European society that we look at, they recommend that patients at risk at nutritional risk before surgery should receive at least 5 to 7 days of nutrition. That to me is very short. It's very little, especially in a patient high risk for eating syndrome where you may only meet goal requirements around 5 to 7 days. They say 7 to 14 days. It's like 2 weeks of nutritional support, and even just that in nutritionally very at-risk patients is shown to improve outcome. So there isn't actually a goal. Like they don't say, okay, when the BMI is 18.5, that's when you can operate. There isn't necessarily that goal, but I think the point is at least 7 to 14 days, and they must be on an improving nutritional trend.
And then the opposite of that is at what point is it not good for surgery in terms of nutrition? Because we often, you have to make that call.
Yes.
And often it's a thumbs up.
Yeah.
So you look at someone and go, they're not fit for surgery, the BMI. So what is that? Simply because I do the occasional head and neck now. I don't do it often enough to know what that criteria would be. Do you know what that is?
So again, I think the literature would be quite vague and just say that any patient at nutritional risk should receive nutritional support prior to surgery, and they don't really give that, bottom line. I think for us, any patient that would be BMI below 16.5, we probably wouldn't be happy with doing surgery. But obviously that's where you come from. If the patient has a BMI 14 and you've actually built an actual BMI 16.8, because that's a very different patient. So I think there's a lot of factors to look into. How much weight did they lost? Are they receiving nutritional support prior to surgery? But I would say, just to give you the straight answer, I probably wouldn't operate in a BMI less than 16.5. Yeah.
I mean, I can understand electrolyte abnormalities because that's something that you can correct. So one just wonders, is it more so should we be focusing more on electrolytes rather than the actual BMI? Because it's difficult, and I wonder whether we've had really messy education that we've taken together that I'm surprisingly well.
Yeah.
I had one patient I remember specifically, it was an laryngectomy and you rested on the table. And he was obviously ICU wouldn't take him, but he was really malnourished. And he came back to the ward first off in spite of that because they were not going to take him to ICU. And he was then discharged from hospital in very empty. Quite fun. So it's amazing what we get away with. But I think the rest of the time it's that kind of thumbs up and a gut feel as to this person is probably not going to be safe. Maybe that's okay, I don't know. Yeah.
So I think electrolyte abnormalities, would definitely be important to look at. But you also have to consider that if a patient is so malnourished, all of your muscular systems will suffer malnutrition, and can their heart, which is a muscle, support the surgery that they will undergo? Do they have enough stores to support the wound healing that is required to take place after surgery? So I think the research is quite clear in that more malnourished patients do worse after surgery, but I understand that we can't delay every surgery by a month to put in a nasopharyngeal tube and keep patients up. It's just not practical. And we are a very resilient population in South Africa. We will do well in these surgeries. We see it in trauma all the time, what some of these trauma patients go through, but they make it through and they're quite resilient. So it's very difficult, but I think what's important is we have the resources available at British Care. We're very lucky in the dietetic department to have what we have there, and we are really willing and happy to support any patients who need nutritional rehabilitation prior to surgery. So 7 to 14 days, that's what I would say is what the guidelines are.
I'm just with what you said about now outside optimism. In upper GI now, we're actually using phase angle as a indicator of outcome. So anything about 5.5 comes up.
Okay.
What we've been using.
That's very interesting. So we've got our in-body machine, which is basically a very non-invasive machine. Have you ever seen on one of those scales that tells you your fat and your water and all of that? So this is a much more high-tech version of that, where it just goes onto a patient's fingers and ankles. The measurement takes like a minute, it's completely painless, and then we can actually print out a report which shows us all of these values, which is really useful. I always regret not doing it on my head and neck cancer patients on day one, because it's always, when they come for their, for example, the total injectable patients generally do incredibly well nutritionally after surgery, before radiation, and I think it would always be nice to see that difference. So I will make a more concerted effort to actually do those readings if you are interested in seeing, the reports. But phase angle is one of the measurements that's becoming more and more used within the nutrition research world, because they are showing some correlation with improved post-surgical outcome. And I think an improvement in phase angle is a very good indicator. Even though the phase angle might start low, just like BMI, an improvement is a very good indicator.
The other thing we need to do is how much patients deteriorate our weight loss surgery.
Yeah.
If I can do measurements when they first get to everybody too. And if they're waiting 6 weeks for surgery, how much do they deteriorate without nutritional supplementation?
Yeah.
And because you might find that you get very strong outcomes if you really put that into nutritional supplementation. So that's always been interesting. So the BMI naturally in Hong Kong, especially people are far leaner and fitter than they are in the US, am I right?
Yeah. So a lot of people is underweight according to BMI, but in fact they're fit.
That's right. So the BMI might not be a good measure. That's what you're saying.
So there's actually different cutoffs for the Asian population and BMI. The cutoffs are much lower than standard BMI cutoffs. So I think, like, for example, where a BMI of 16 would be malnourished, a BMI of 16 may be normal for the Asian population. So they have actually adjusted BMI. But I mean, BMI in and of itself has many flaws. So
that's good, because maybe the African population might be.
It is something that we actually need to speak about having a shifted BMI range for South Africa, but the problem is that we need to be shifted on both sides of the BMI scale, which is a big problem.
Yeah. So we have to be cautious to extrapolate data elsewhere. That's why I'm leaving that with it.
Absolutely.
Yeah, I think to add what Prof. Refeeding said, I think our patients often present much later. I think as soon as the cancer is there is a metabolic derangement. So when they present later, that metabolic derangement will be there for much longer. And then I think there are also certain tumor factors that play a role. Certain tumors are rapidly progressing, high metabolic demand, which impacts the rest of the system, while some are slow growing, indolent, and doesn't really affect the metabolic profile of the patient. All these play a role, but what's interesting to me, if you compare to the patients from first world countries that present in a malnourished state, so we assume ours is much higher, yet our outcomes are very similar
Yeah.
So
to
true.
what it is
Yeah.
overseas. So either our post-operative management is extremely good, or we overestimate the impact that nutrition has on the recovery, because that's why some emaciated patients that do extremely well, and others that don't do well, and we haven't figured out exactly what the issue is. It's the surgeon. Yeah, I think there's a lot more to discover, which I think is, and the same as with BMI, I think the studies need to be done on our population profile, and we might come up with different conclusions and different answers.
Yeah, absolutely. Absolutely. Yeah. Yeah. I think the local
Sorry,
data
that-
is very
I think it's also be interesting to see that, because I mean, the feeds that we get, they come from overseas, isn't it?
important.
So the quality of your calories is, I think, is also important. You know, if having high energy isn't necessarily good, you should also maybe look at your fats and your proteins and and your quality of proteins and your fats, and that will also assist in the recovery and prevention of metabolic syndrome.
Yes,
It's a
absolutely.
very, it's actually extremely complicated. We're sort of trying to get a blanket. I mean, it can actually be very specialized management for all of these different patients.
Yeah, and I think nutrition research in and of itself is very challenging because it's really just one factor in a very complex system. And nutrition research, yeah, it's a very tricky thing to do and to get right. But obviously, the more data that we can collect, the better.
Yeah.
So I think I'm really going to make more of a concerted effort to try, find the time to do in-body and most of the patients, just to start collecting data, even if it's just for our own use, just to get an idea before we can get a real study up and running. Just one thing I want to ask. So, one of the studies brought forward by Dr. White to potentially do a refeeding type study, we'd be looking at the rates of refeeding syndrome as well as identifying the risk factors and doing a risk stratification, very similar to the study, the observational study that I showed. It's quite difficult to determine the rates of refeeding syndrome where we are already managing refeeding syndrome within this population. Technically, I already have a refeeding syndrome protocol in place, which I'm using. So I think it's also just important to take that into consideration that we may not be seeing that much refeeding syndrome within this patient group, and luckily most of the time have good tests CMPs, they actually are normal, but I think these patients are already being treated within a refeeding syndrome protocol. So it's just something to consider, and I'm not sure how that kind of affects the research. I'm not saying it's not worth doing the research, it definitely is, but it's just something to consider that.
Well, we have got, we've quite all other African trained people, so we could always extend it to Madagascar, where they might not have more sort of facilities available, yeah.
Very stupid question. So, patients that you're feeding up, say, prior to surgery, and they're giving them this, is it intro, whatever?
Yeah, like crazy things.
But those are very expensive. When I'm not any of you guys have Refeeding in Kenya.
They're actually limited to ICU patients.
Yeah. So what are you doing and some patients in private where the medical aid schemes don't actually cover Refeeding. What would you recommend in place of that if patients, because soup's obviously not got enough calories.
Yeah.
What do you do with those?
There is
Yeah,
And no, seriously, not the same.